Thank you. Fine, that's enough. I was told this was going to be a small meeting. Right. Thank you very much for inviting me. I was a GP for 30 years. I have actually recently retired from the clinical work. And I would just like to say thank you for inviting me, but secondly, it's been a real privilege, and I have felt extraordinarily lucky to work with so many amazing patients, organisations, staff and carers over the last 4 to 5 years, working with West Kent CCG and other colleagues right across Kent and Medway. When I'm in Medway, that's Medway and Kent, but it has been a real privilege. So I'm going to talk today very briefly, in about 15 minutes, really about some of the achievements in local care, and I'll explain what local care is, and really the challenges, some of perhaps the big picture challenges which remain, not just from a commissioning point of view, but really from everybody's point of view, from the patient right through to the trusts and providers. So we know where we all started. Quite a long time ago, 50 years ago, and this is what 4 wheels looked like 50 years ago, and this is what a dashboard looked like, and climate control down there was either on or off. 50 years later, it all looks pretty different, but particularly the control panel in the middle. And the control panel in the middle can tell us which bits of the system are working together. 3 engines and 1 battery. And actually, we can get real-time what works what, with what, how much someone's working, which pathway is working. And in a car, it's really important now to know which bits you're doing so you drive it properly. But pathways and the journey that we take are terribly important. So when I started my journey in general practice, the pathway that I worked on was pretty simple. I had a desk, there was no computer, there was a telephone. And if I had somebody that I thought might have bowel cancer, I would do an examination, I would take a biopsy, and I would phone Peter and say, "Hi, I've just got the histology back, they've got bowel cancer." And he said, "Oh, book them into my list." And that was the pathway. I can remember calling the consultant psychiatrist. He had a gold Rolls Royce. I called him as much as I could, because I love to see him try to park on East Malling Estate in his gold Rolls Royce. And the pathway was me picking up the telephone. And he would come and we would do a joint visit. And I did a bit of psychiatry before general practice, but I learned so much from sitting in the same room as the patient and the person that was going to look after him. And then the pathway included me visiting the hospital to see the patient. So I planned the recovery and the discharge with the patient. Pathways have changed, but they are really, really, really important. And why are they important? They're particularly important now because patients like to know what journey they're about to go on. And do they want to engage in that journey? They need to be able to be part of that journey. So we need also the pathways to describe from a commissioning point of view, what is it that the specifications need to clarify? What do we need to actually describe for this patient? What are the outcomes that we want? It's increasingly IT driven. And is the right care being given in the right place by the right team? Do the pathways describe capacity and continuity? And very importantly, can we judge what the cost is going to be? Because do we actually know how many patients are going to enter the pathway in the first place? It's been a great privilege working with the teams where we've done the clinical transformation for instance, children's and eating disorders, and we've introduced self-referral. That was a bit of a should we do this sort of moment, but it's worked really, really well. And a lot of the things we've done with KMPT in terms of changing systems have been very positive because we've taken a bit of a step into the unknown. Not everything is evidenced. So the pathways help us to look at quality and outcomes. But most importantly, perhaps, the pathways really need and increasingly need to help us reduce duplication and service gaps. So primary care is now better described really as an MDT. And it's local care now because For instance, in West Kent, we've got all of the GPs have come together, the practices have come together, and have formed clusters. There are 7 clusters in West Kent. But more importantly than that, in a sense, is that we now have teams around those clusters of practices. And those teams involve a remarkable number of people, which I'll tell you about in a minute. But a lot of these changes within primary care, now we will call local care because they involve more people, are hindered by financial and staffing crises, are ongoing in every sector in the health service, persisting pathway isolation because they're not really joined up necessarily in the way that they should be, falling morale and diminishing educational opportunities really are sort of chronically grumbling along still at the moment. There are lots of positive things happening, but there are issues with the service across all sectors which we need to address, and education, in my view, really is ignored in terms of its potency to improve morale. So here is now, I know you can't see this, but it doesn't matter. But this is one of the final diagrams that we've used to describe commissioning in local care. The most important thing is, in the middle of this diagram is the patient. And around the patient, we now have a primary care service, now called local care, which is supported by a cluster. And that is a group of practices, but as I say, more importantly, are the primary care teams, the local care teams. And these teams will involve complex care nurses, heart failure nurses, COPD nurses. We've got terminal care services and nurses and specialist nurses. We have mental health care nurses, which over 3 to 4 years we've developed new primary care specialist nurses who are now working. We have 8 in West Kent, and I know other areas in Kent have the same, and Medway. And these nurses will work within solely the local care service. They will enter notes on the GP systems, and they will encourage and help earlier discharge from hospital. We have care navigators, we have health and social care coordinators supporting the system, because not everybody can be looked after with the intimate team. We need to be part of a much bigger team, and that is represented so well amongst all of you in the room today, and the charitable and voluntary sectors. So local care now is a much bigger system, but there is a problem with that. Historically, and it's not much different now, is looking at the money, is that 90% of the money is spent in what is called secondary care, or let's call it specialist care, and 10% historically in local care. Let's propose it's more a bit like this at the moment. So local care has grown. It's expected to do more. It's expected to look after much more complex illness. We have GPs who now provide perhaps what might call the old general physician care of say, the early 2000s and 1990s. But there is no more money in local care to do this. Equally, there's no flow of money from the secondary care sector into the primary care sector. And 2 of the reasons for this are quite simply is that it costs a lot of money to run the secondary care sector. And also in mental health in Kent, we're actually pretty reasonably underfunded compared to the national average. So mental health financially is under a lot of strain within Kent and Medway. So how can local care best deliver to patients the care that they require? So here's our GP representing our local care, but it could equally be any one of that team. And they're looking out for buddies to organise care. So off we go. And who do we find? Well, actually, it's quite difficult to find somebody because the system that we work in, how it's set up, doesn't allow people to easily work together. The fiscal systems tend to prevent it. But what local care has done in Kent and Medway, it's done this. It's organised itself. It has a lot more places that care can be provided. It has more structures. It has more teams. It has an MDT which drives it. So it has a multidisciplinary team where everybody sits down. The primary care mental health nurses do go to these meetings as well, although they're not fully integrated into this because this was set up to deal with physical health care frailty, which was a really expensive part of the system, but more importantly, to try and deliver better care to patients at their home. But you'll see on this diagram, in fact, we are joined to the mainland. In other words, we're joined to secondary care, but it's a little bit tenuous. And the NHS, to lots of people, still feels a bit like this. We still feel like everyone's on their own island, and patients can feel quite isolated at times because they get stuck and there are gaps in the service. But that's because the pathways are not well described once patients have left primary care and the local care setting. But there were lots of positive things happening. We've got Glenn Douglas sitting down here in front of us, who's the new AO for 6, or it might be seven CCG areas in Kent and Medway now. And there's a strategic CCG. We're trying to get some uniform, positive, identifiable ways of transforming the system across Kent and Medway. But what has to underpin this is improved clinical care pathways, so patients can be followed, be known and identified and feel safe within that system. There's a new clinical cabinet, which again is pan-Kent and Medway for the most part with CCGs. And this clinical cabinet is going to look at improving the flow of patients and identifying how patients should move effectively and efficiently in a caring way through this system. Does this mean that the integrated care systems, that's what ICS stands for, is going to facilitate this? Well, it must. It has to make sure people work more collaboratively. At the moment, that isn't happening as well as it should, but it definitely needs to. And if everybody is looking at a single pot of money and they think, well, I need my bit of that, it will engender better communication, better collaboration, and people feeling they're on the same page because they're looking after the patient. Forgive me saying patient, because I know client and service user is an equal term, but it's the one that flows out of my mouth, I'm afraid. But what do we need to do? Well, this is what we need to do for NHS England on the 5-year forward view. We need 70,000 more adult consultations. We need 30,000 more patients going into the MIM service, which we heard a remarkable presentation earlier. We need to reduce suicides by 10%. But all these are targets. These are boxes to tick. But the pathway to describe how we get there is never described to us. So we've got to actually make sure that we do this. So what does local care need? I've bolded one of these because it is the most important thing. If there's one message that I really would like to get across, is that we must have specialist support throughout the local care mental health pathways. It is the only way of stopping referrals where patients get stopped, where there's a gap, or patients get rejected within the pathway. We need quick and understandable access for urgent care, something that patients and all health professionals know how to use. We need an integrated physical and mental health care teams that look after individuals. So we need physical and mental health care teams to be in a team. We need rapid escalation and recovery pathways so that specialist care is used efficiently, and we need resources in local care to make sure that this all happens effectively. We need an integrated public health, local authority and voluntary and charitable sector who are equals in this system. And when I presented this to a friend, he goes, well, he says, what planet do you live on? Well, if you live in planet Cambridge, they're doing it all. I went up there 2 or 3 times recently, and they are doing everything that I've just described. They're not the only place in the country. There aren't many people doing it, and we all have the aspiration to get there. But having seen a CCG which has done it, and providers that have done it, is very special. And in fact, we're going to try and in West Kent is to take this one step further. Because the advantages of PRISM, which is what the Cambridge system is called, is it maximises primary care and mental health resources in local care. It is all based around a patient recovery model. It's all about the patient being well, getting better quickly in recovery, and keeping them in recovery, helping them to find that esteem and that wellness and that well-being that keeps them at home, in employment, in a house, in a flat, with their family and friends. Parity of esteem is accepted. It's integrated. I think we're still struggling with that in Kent and Medway, and I think there's a lot more work for us to do on that. There's a huge amount of collaboration between primary care and secondary care in Cambridge. If I was to tell you that they have consultant physicians, consultant psychiatrists, consultant geriatricians, care of the elderly, consultant rheumatologists in the same team with all the other healthcare professionals, with consultant psychologists, OTs, all working in one team, not in different trusts, but in one team. When I heard that, I thought, this is what we need to go to. So our challenge is to create a system change that enables care to deliver local care that fully integrates mental health and social care, supported by necessary funding to create that change and end gaps in the delivery of care, so patients get what they want, what they need, when they need it, and don't have stops along the way. So, is this mission possible? Yes, it is. It is possible because others have done it, and they're in a slightly different position. So I make no apology for the last two slides. They're a bit busy, but I think that some of the things on here are important, and these are off the top of my head, so they're not on a labelled slide, but I'd just like to go through them. I'd like to propose that some of these we need to achieve quickly. So the current common clinical boundaries separating primary and secondary patient care should be disbanded to allow the establishment of collaborative clinical health and social care based on patient need. That should underpin everything that we do. Specialists and generalist clinicians, healthcare professionals, and voluntary and charitable sector should all be identifiable within described whole teams that reach across historical healthcare referral boundaries. So just as we heard wonderfully earlier that inside NELFT there aren't any referrals, it's all integrated. That's what we need to achieve in the whole system. We need new integrated care systems that should fully support patient care led with clinically agreed evidence, but that evidence can be evidential, it could be experiential, quantitative, or qualitative. We need to be careful about only doing things that are scientifically evidenced. Acute community mental health care trusts and authorities must be required to create clinical and social teams that provide integrated mental health and physical health care. And from a commissioning point of view, the focus should be on prevention, improvement, and maintenance of patient-experienced health in recovery. So shared experience and knowledge and collective education, as I mentioned earlier, should be core to all healthcare provision. It's no good having only one part of the pathway educated in the pathway it's providing. And Health Education England is essential to this aim. I still feel Health Education England is a little bit distant. All clinical and social teams must have appropriate patient representation, and we're a long way from achieving that still. There's a lot more work to do with that. Managed population areas need to be of a size to be fiscally robust and stable enough to ensure required local variations. Local care, the care we provide around the patient's home, needs to be very different in some areas across Kent and Medway. So we need to make sure that our fiscal footprints are safe enough to do that. And perhaps most importantly, and this is why I think, and talking to the Cambridge people, this is why it's worked there, is the boundaries of managed patient populations should, as far as possible, match the boundaries of providers with local authorities. Where this does not occur, the boundaries of current CCGs and providers should change. But as a default, providers must work collaboratively to provide all necessary services and staff across historical boundaries to ensure care is delivered seamlessly as described in clinical pathways. So in other words, we get to that point where we can have joint teams with all the people required in teams. They don't have to be employed by the same people, they just need to be in the same team. So what's it like working in the NHS and in local care? Well, it can feel like this. It shouldn't have to feel like pulling teeth a lot of the time. So I'd encourage us in the new world, which Glenn's going to lead us through, aren't you, Glenn?
No pressure.
No pressure. That actually, let's all pull together. And I really, really think that we have a lot of opportunities, a lot of great leaders, actually, who can take us there. And I wish us all well on that journey. Thank you.